welcome to Long COVID Foundation podcast. My name is Dr. Valentina Viduta and I'm a Long COVID Foundation trustee. This channel is for long COVID sufferers, researchers, practitioners, and a whole host of other people who wants to learn more on COVID. The Long COVID Foundation aims to find the best rehabilitation solutions for long COVID sufferers. We provide the knowledge that you can use to understand your symptoms better. So please subscribe to our YouTube channel and like our videos.
Hello, Sanchi Baranova. I'm glad to see everybody. Today we have very interesting meeting, and also we have other participants, which I would rather have them to present themselves. Let's start with Valentina. Valentina.
Hello, everyone, and my name is Dr. Valentina Viduta, and I'm a Long COVID Foundation trustee. The Long COVID Foundation is the first registered charity in the UK, and we aim to support long COVID sufferers across the globe. Thank you.
Varvara.
Hello, my name is Varvara Ryabkova, and I'm a laboratory assistant in the Laboratory of Mosaics of Autoimmunity in St. Petersburg State University, Russia. I work under the direction of Professor Igor Schoenfeld, a world-known specialist in autoimmune diseases, and I'm one of the research coordinators in the research direction of chronic fatigue syndrome, fibromyalgia, and the long COVID. We are working in our laboratory in these directions.
Irina.
Hello, my name is Irina Nikitina. I'm a practitioner in the state of Virginia, Washington, D.C., and I've been in practice for 14 years treating Lyme disease, which is very common in our area, and also chronic fatigue and other conditions.
So we have here a constellation of specialists who are working in different directions, but all those areas somehow talking to each other and intersecting with each other. Let's name those areas again. We have Lyme disease, we have chronic fatigue syndrome, and we also have post-COVID or long COVID-19 syndrome. So what is common between those three conditions? Irina, maybe we will start with you.
I've been seeing patients since 2007. By chance, pure chance, I've been introduced to the very controversial area of Lyme disease co-infection and other conditions. Since we have the topic today of chronic fatigue syndrome, I would like to give my perspective on that condition, because in US we do have acknowledged diagnosis of that syndrome. So as I understand, it's different in Russia right now and maybe in Europe. But here we can actually, from the clinical point, we can put this diagnosis for insurance purposes. The treatment is going to be covered. As I've been going through my journey treating this condition, I understand that it's not necessary a diagnosis by itself. It's a complex multisystemic failure. And whatever cause it is, it's basically a tipping point of that perfect storm that's going to be affecting all the systems. And that's how I approach it, again, from the clinical point. That's how I approach the treatment. Using some diagnosis that would be very helpful, but it's not that I'm telling my patients that, oh, you only have this and we're going to concentrate on this. Because the integrative medicine is mostly, inclusive medicine. So you have to treat the human being as a whole system, not just a particular one condition and just move to another. It has to be approached based on the clinical presentation, of course. Whatever is failing, you have to pick it up, but you need to have a plan in mind that you're going to treat the whole body.
So I think that there are a lot of parallels with post-COVID or long COVID, because this condition is so polymorphic, and we see in some people there is more involvement of the heart and vascular system, and other people we have systemic vasculitis, but heart is seemingly not involved. In other people, we have liver problem, pancreatic problem, diabetes. We have intersections with chronic fatigue syndrome because there is a fatigue. And of course, those patients not yet fulfilling criteria for chronic fatigue syndrome, because one of the criteria is to have this condition for 6 months or more. And the majority of the post-COVID patients simply not there yet. We are certainly going into this direction in the very long cases of the COVID. And of course, last but not least, neurological consequences of coronavirus. And this, of course, is very important thing. And we are hopefully will, get something from your experience to share. Varvara, tell us your perspective on all this.
We are working in our laboratory on chronic fatigue syndrome for more than a year, and we started with chronic fatigue syndrome, but now we have more and more patients who still have some symptoms after they meet with COVID infection. These patients also approached us. We work with patients from the patients community because chronic fatigue syndrome or long COVID are not approached in Russia, not diagnosed. So the main base of our patients from the patients community. Actually, patients with long COVID, not all of them have fatigue, but most of them have chronic fatigue. I think that long COVID is more heterogeneous than chronic fatigue syndrome, but chronic fatigue syndrome is also very heterogeneous. We are just starting working with these patients, and we are going to organize a clinical center in our university for long COVID and maybe also for chronic fatigue syndrome.
Thank you, Varvara. Valentina, how about question for you? Can you tell us from UK perspective, are those two conditions, chronic fatigue and post-COVID, differentiated from each other, and both of them recognized right now?
I will be telling that from patient perspective, not from medical perspective, but I will give an overview what is currently happening in providing guidelines for medics, how to treat post-COVID and how to deal with CFS. What we see now is the post-COVID is defined here as the syndrome, which takes 12 and more weeks. So up until then, it is not counted as long COVID. So up until then, people are not included into any registers as long COVID patients, and they are being treated as simple post-viral infection. After 12 weeks, some of them are being referred to long COVID clinics, but it is a new disease, a new syndrome, and still guidelines are being developed for those patients and medics. And as a foundation, we aim to help medics to do proper job and proper guidelines based on patients, what we see on their symptoms. Fatigue, yes, is the very common symptom what we see in our group on post-COVID recovery support group on Facebook. It is one of the most common we see, and the second one is the brain fog. So these two are very close to each other. And we don't know whether it is CFS or it is induced by long COVID itself. As I said, long COVID is not yet clearly defined and not clearly distinguished between CFS or long COVID itself. We definitely need to look into it from medical perspective and see what kind of diagnostics and tests need to be done to properly distinguish between those two, because CFS, as for example, Varvara said, is one type of illness, and long COVID patients may not have fatigue, but it's still long COVID illness by itself. So we can't say that CFS is exactly the same as long COVID. So there should be clear definition for that. And we definitely need to be based on some medical diagnostics and blood tests or whatever it is possible to identify. So CFS has been treated in the UK, and there are some guidelines how to treat it. Again, it's a very time-consuming process, and medics mainly treat symptoms rather than trying to identify where it came from. because it can be financially quite expensive to do, or maybe we still don't have very advanced laboratories to identify CFS, but we do treat symptoms. And symptoms from CFS are very similar to post-COVID, but again, there should be clear definition for post-COVID yet identified.
With all that, I think that we can draw some experience from CFS treatment and bring it into post-COVID treatment, and maybe back as well. Maybe it would be working in the opposite direction as well. But let's start with CFS as more or less understood condition in comparison to post-COVID. So it would be very interesting for me to hear diagnostic perspective from both of you, from Irina and from Varvara. And as Irina is handling those patients in real practice, maybe she could add something on actual results in the patients and what exactly is the most straightforward way to get to the root of things, in particularly in the case of CFS. Let's start with you, Varvara.
In our study, we approach patients with questionnaires. We have the Pole Symptoms Questionnaire version 2, and now we had that the majority of patients from the patients community who think that they have CFS, they actually filled in these questionnaires and they met criteria for types of criteria: Fukuda criteria, Canadian consensus criteria, international consensus criteria, and criteria of the IOM, Institute of Medical of USA. So it's our way we diagnose CFS, and also we exclude other conditions with similar symptoms. Our patients usually have a lot of tests, a lot of investigations they have already done, so it's not very hard to exclude. Actually, we have some patients with subclinical depression or anxiety, or clinical depression and anxiety, and I'm not sure about how to exclude or not to include these patients, because in the last guidelines I have seen, they suggested not to include patients with mental diseases who have their treatment but still have chronic fatigue. I would like to ask Irina about these questions. And what more about diagnosis? As far as I'm concerned, we have 2 days cardiopulmonary exercise test as objective measure of fatigue and diagnosing of chronic fatigue syndrome, but unfortunately we don't have this method in our clinic. What about our work as a scientific laboratory? We tested microcirculation, small fiber neuropathy, and a lot of autoantibodies, not typical autoantibodies, but those that are not tested in routine clinical practice. And also we have a battery of neuropsychological tests regarding brain fog. So this is the way we work in this area.
Thank you so much, Varvara. Irina, please.
Again, I want to bring it to the different point of view that from the clinical side, we don't need to include anyone in the study. So basically, we see patients who are more interested in just treatment versus forming a group and, investigate further. However, it's the same paradigm goes as you described, with CFS being diagnosis by exclusion, and by analogy, same goes with Lyme, because, you have to exclude all these things for the reason that there are no sensitive tests to that. However, we start, this is a little bit different group of people maybe that comes to my practice versus coming to you, because in my case, I get patients who have that for the long time, and they're already been screened by numerous doctors, and they already been referred through the whole chain of neurologists, cardiologists, the rheumatologists, of course, psychiatry is always there, because that's the knee-jerk response of any primary care, just it's all in your head. And these people are very traumatized. They come in already with a big pile of papers and we just review them. However, again, I don't have lots of experience with post-COVID syndrome only because it's so new. And by nature, my practice and not accepting the new patients, not necessary with post-COVID syndrome, so they come already with concerns before the COVID started. With that in mind, all my existing patients are already on the protocols and they are super cautious of not getting any exposure. So, it's a little bit different group. So I don't have that much of post-COVID experience. But from the point of diagnosing, let's say I have a new patient coming in my door and they already have the symptoms for the 6 months mostly. So my first screening, let's say they didn't have the extended history of tests and doctor's visits. So they come complaining, most of them, with a fatigue. If not, it's a complex. They complain of brain fog, of course. Most of them will have some arthropathy and joint problems. They might have lots of neurologic symptoms. And definitely the cognition is always the problem. So we start investigating usually, again, based on our area, it's endemic here, the tick-borne illnesses. So what I offer them is the battery of tests that in our country is very easy to be covered by insurance. So this common test, if they have insurance, they're not going to be charged a lot. I'm trying to save the money because it's a long and very expensive process. So anything will help. So I don't want to order multiple battery of tests, that they're going to spend their resources right there in the beginning because they need a kind of long-term plan. It's not going to be cured within a couple months. It usually takes from 6 months and up. The first thing, of course, I will order the complete count, the blood count, so CBC, chemistry, of course, we're always checking the liver. Based on the symptoms they present in first, I will order most likely the co-infection panel, which is, I can go into that if you're interested, and a Lyme Western blot. That's as far as we go with the tick-borne illnesses. Next, again, if there is any fatigue and other symptomology, like I'm suspecting that the hormonal involvement is usually the case, I check always for thyroid panel to rule out, obviously, any problems with thyroid. And then I only screen very basic with some of the autoimmune conditions. Because again, I'm not trying to treat them for autoimmune. I'm not a rheumatologist for that matter. But if there is a serious concern, they're going to be referred to open-minded rheumatologist. Because through the practice, we develop these connections with the specialists who are more open-minded and they agreeing with the basic of what we're doing, so it's not, it takes some time to develop these connections. And then, of course, based on the symptoms, I'm checking, again, what their vitamin D level, what there are, if they have anemia, if they have any abnormalities, other vitamins, only because this is diagnosis by exclusion. In certain cases, if they have problems with GI, with gastrointestinal system, we might choose to use that different lab that have an very extensive diagnosis. It's a stool test, and we check in that only because where it's all started, I wouldn't be able to treat them if their GI is not working well. So I'm not trying to overtreat them, but if there is a severe, let's say they have obvious indigestion or malabsorption or something, again, I don't want to treat the symptoms. I would like to find the cause, the root of all of this, what it's driving. So basically, based on the presentation, I will do all of this. And then if something is not right, I will then do the extensive test based on that problem.
Excuse me, can you tell more about infectious panel and diagnosis of Lyme? Use ELISA test or Western blot, and what type of autoantibodies, IgM or IgG or IgM do you test, and of what type of result you think positive and what type you think negative?
So again, we don't have very sensitive tests, as you know. We don't even bother to order ELISA at this point. So we jump in right in Western blot, and that all depends on the labs, because the labs that commonly we use that insurance cover will only test few bands, obviously do the IgG, IgM, but they only do certain bands, and there are more specific bands, one versus another. So giving you an example, they only doing like they have a strict criteria, only 3 bands, for IgM, and I'm arguing about that always with outside clinicians, that if we want even at the chronic state to have the immune system to be active constantly at this level, how you can just pick and choose few bands and then base your diagnosis on that. So in order to overcome that, again, it's more like a screening process. First, they do the most common labs, and then if nothing is showing on that, but symptoms are still very significant to support my suspicion of Lyme or co-infection, then I send them to another lab, which is located in California. It's called IGeneX, and they have a higher level of sensitivity and specificity, and they actually testing so much more at the more advanced practice. Sometimes it might come clean. Sometimes it might come as a co-infection, positive. But again, I always tell in my patients that I'm not treating their papers, I'm treating their bodies. So in this sense, if they're obviously very sick, their symptom score, I'm trying to ask them to screen every single time to screen their condition. I do the symptom score. So they just check in from 0 to 3, lots of symptoms every single visit, and then I trace it based on our treatment, what the response. It's useful for the clinical. I'm not sure if it's going to be useful for your purposes, but in this sense, I'm just seeing that the picture, the presentation, how symptomatic they are, it's not really correlates with the clear labs. So we continue looking for that. And the fact that here we know that most ticks are contaminated not just with Borrelia burgdorferi, but other what we call co-infections. Most commonly in our area, it's Babesia, Bartonella, Ehrlichia. We have Rickettsia, and we have also a lot of Mycoplasma here. We screen all of this on the, again, different levels, more sensitive, less sensitive, and then through labs. And then we usually see one of these co-infections being positive. So that will confirm the fact that they've been bitten by a tick, they've been exposed to all of this potential microorganism, and then we treat them based on that. So it works, and in the process, because you have to really not only kill the bacteria, basically, you need to support your body as a whole. We have to address the CFS, because in my experience, it's not a particular disease by itself, like say, rheumatoid arthritis. It's not the same. It's a complex issue. And I respectively disagree that we might see that same paradigm in post-COVID syndrome, because don't believe it's just a condition. I think it's just a complex of multisystemic failure.
Okay, and one more question about herpes virus infection. A lot of people with CFS in Russia think that their symptoms are related to herpes virus infection, in particular Epstein-Barr virus, cytomegalovirus, and herpes virus 6 and 7. What do you think about it?
99% of all human beings will have some of those viruses. We're exposed to them through our lifespan. So in the sense, most of them are going to stay with you, and just in a more latent form, and will come up only during the time when your immune system is down. From the point, is it really the cause? Because it might be in certain populations, if they already have their immune system compromised, and then they got hit with, let's say, mononucleosis, and they cannot recover from that. But in order to do this, you have to have some kind of problems before already. It's not going to just put you in that disabling condition, just having a virus. It's usually the tipping point. It's some last drop that's going to fill that glass, and then everything spills out.
Do you use valciclovir, ganciclovir, or aciclovir for these cases or not?
Again, I use it if it's necessary. Patient who already been having chronic fatigue, and been sick for a long time, and suddenly they develop shingles, for example. Of course, yes, I do use it, and it might help. But should I base my treatment on that only because I see a trace of these viruses there? I don't do this. I only do it based on the picture of that particular patient, because there is no standardized treatment for any of this. It's all based on what patient presents with.
Okay, thank you.
Great. I think now it's time to discuss a little bit at autoimmune manifestations of all those three conditions. And I think it would be great if Varvara will tell us a little bit about their work in the laboratory of mosaic of autoimmunity, because that is exactly looking at various kinds of type of auto antibodies which we are seeing in patients. Varvara.
Okay, thank you. Yes, patients with chronic fatigue syndrome and patients with post-COVID-19 syndrome have some symptoms which are very similar to those we seen in autoimmune diseases. It's not only arthralgia or arthropathy, but also muscle pain and Zika syndrome and hair loss. And some of our patients have ANA positive. And sometimes rheumatologists who see these patients, they diagnose undifferentiated autoimmune diseases or connective tissue problems, but not specialized. And this way, these patients come to us. Actually, there are different situations. Sometimes for post-COVID or post-infectious period, it's typical to have ANA positive, and some symptoms can persist. So we don't think that this is autoimmune disease until some time will gone. But actually, we also have some special tests. We have tests for autoantibodies against different organs and organ systems. and we screen these autoantibodies, and we think that some patients can have autoimmune process, maybe in a low degree. So we consider, for example, steroid therapy in some cases, not in all cases, but in some cases, when we have the symptoms related to autoimmune diseases very great.
Just out of my curiosity, Varvara, are you using any spot tests like Eli Viscera, etc. by Dr. Poletaev? Is it that brand?
Yes, we have very nice contacts with Dr. Poletaev and his laboratory, and we use these tests. Yeah.
He died recently of post-COVID, I heard.
Yes.
Yes. Very sad story. A lot of people died in every country, and doctors and people who develop research tests are among them. So when we list those lists, there are always people who we know, unfortunately. So about those Eli Viscera tests, maybe you can tell us a little bit more details, because I think that patients in UK might not know what it is. And Irina, do you know what Varvara is talking about? What is
No.
the analog? What is the analog in the United States? I'm not sure whether we have those kinds of tests.
What is it? If you can give a little bit overview of it, what it does.
Yes, Eli Viscera test is a test for autoantibodies against different organs. For example, against thyroid, against gastrointestinal tract, against myocardial autoantigens. These are not routine autoantibodies, which are tested in rheumatology practice, but the main idea is that if we have some damage to any cell, we have apoptosis, for example, our body reacts with the secretion of production of autoantibodies against this organ. So we can diagnose the damage to any type of cells, any type of tissues in very early period. So it's a type of early diagnosis of any dysfunction or any damage to different organs. It's not only deal with autoimmune reaction itself, but also the damage or increased function of any organs, because if we have increased function of some organ system, we have upregulated expression of different proteins related to this tissue, and so we have more autoantibodies against these antigens.
So to clarify, those are polyclonal antibodies which are against variety of the antigens in particular tissue. It's not a classical test how we measure, for example, in thyroid, we measure basically 3 antibodies, 2 for hypothyroidism and 1 additional for Graves' disease. In this case, thyroid will be seen as complex organ, and whatever reacts in thyroid, even if it's outside classical 3 antigens, it will be all counted as a sum. So it's an Eli spot. It's every spot is a spot. Yes, so it's not a it's still a semi-quantitative analysis, but it's not a completely quantitative analysis. The strength of the signal will be measured in relationship to other spots, and then put on certain scale, and the scale help clinician to match it with some kind of functional disorder in one or another tissue. Am I correct, Varvara?
Yes, you're correct.
Can it identify brain fog, for example, if it was induced by
Actually, we have Eli neuro test, not only Eli Viscera test, but also Eli neuro test. And in this test, we tested autoantibodies against 12 different neuroantigens. For example, against receptors of GABA, serotonin, noradrenaline, dopamine, and against some other neuroantigens. So these tests have been used in different neurologic and psychiatric disorders, and we have already some results in chronic fatigue syndrome, for example. People with chronic fatigue syndrome who have brain fog very often. They have upregulated autoimmune response to neurologic antigens.
Valentina, I have a question for you. So you see, we have quite different diagnostic approaches in United States and in Russia. What do you know about how patients diagnosed in United Kingdom, and what is a typical patient journey there? So where it starts, and I mean, I know it didn't end yet, but where are those patients? Where they ending up?
I'm very actually surprised to hear that in America you do lots of tests and you're very accurate about what you do next, and you dig down into identifying the real cause. Unfortunately, the picture in UK is not that great.
Just a correction, Irina is a specialist in integrative medicine, and not every practice in the United States is doing it that way. I brought to you a very special doctor because I pick and choose by hands. Yes, if you will talk with a garden variety physician in the United States, probably he will tell you something which I don't want to hear on my channel. Yeah, so go ahead, tell us about Great Britain.
So what I see from patient perspective here, and I can comment only on that. Unfortunately, long COVID clinics that were set up specifically to see long COVID patients, they are more focused on rehabilitation path. So basically, these clinics are designed to help people recover. And the recovery itself is more based on physiotherapy, on breathing exercises, on maybe yoga, on wellness activities or specific diets. It's not very thorough medical diagnostic that people would expect from a long COVID clinic, even though it sounds really, simple rehabilitation path. People still struggle to get to these clinics. And on GP level, so general practitioner level, people usually would have general blood tests, again, to identify for infection level, CRP, and maybe if they're lucky to get vitamin D deficiency, B levels. And this would be it. And the question with long COVID is that most of these blood tests come as normal. And doctors are not sure what to do next with these patients. And most of them are referred to antidepressant pathway to help them deal with this anxiety and sleep disorders, and considering this as a treatment for long COVID symptoms. For some, it may work if they do have these depression symptoms, which are real. For some, not. So basically identifying the real cause for long COVID is really difficult, and we don't do this thorough autoimmune disease tests. Only these tests would be performed, I would believe, if their people would be attached to some kind of studies that are undergoing in the country. And there are currently a couple of centers who do these studies. So they take people on board and they do proper scans, do proper MRI scans, because most of x-rays, for example, chest x-rays, they would be clear when people still struggle to breathe and they still have mucus and they still cough. So it's more chronic cough, and x-rays are clear. And again, at the GP level, the treatment is over. So you may take antibiotics, which would harm you more than treat you. And you may be lucky enough to get to a long COVID clinic where you will be treated for the symptoms, as I said. So it can be breathing exercises, it can be physiotherapy to help you move around with the fatigue, for example. And this is it. So it's, as I said, it's really great to hear that in the USA and Russia, you do quite a lot of testing on people, and I hope this is gonna be scaled up across different centers and different medical practices, because long COVID sufferers need these tests and they need to be properly scanned.
Well, we have a hope that those practices will be scaled up in our respective countries too, in the United States and in Russia. I really brought together people who really do stuff. So it's not really what's going on in every single place within the country, but that's what we are trying to do, exchange experience and at least make patients aware that options exist, because very often when patients start their journey, they don't know where to start, and they start with place which is near their home, so they go to doctor, they go usually, and suddenly they receive very cold response, like maybe something wrong with you inside your head, maybe you need to relax, maybe it's stress, and stress is really not something which is treated in this case, but the best case scenario, you get antidepressant. In the United States, the policy on antidepressants very loose, especially with COVID. I mean, before COVID, we offered antidepressants left and right. But after COVID came, to get antidepressant, if anybody wants to get it, it's really not a problem. And I know it's quite opposite in Russia, and in the United Kingdom right now, it's more leaning toward the American path rather than Russian path, but still it does not provide a treatment, but rather mask a problem, and patient might feel that it is better this way, and he can cope or she can cope with symptoms better.
And before that, sorry, if I can interrupt, and with the antidepressant tablets as well, I can give a case and to have your opinion on or advice what you would do if you would see this patient in your clinic or in your study, Varvara. So we had a patient in the group who was tested positive for coronavirus twice, and he started to be short of breath, fatigue, sleep disorders. Previously, he was on ID tablets, which were continuously changed. So as he had the story of depression in the past, so the long COVID sleep disorder was attached to sleep to depression, and he was continuously on AD tablets now. Then the symptoms started to be more severe in GI. Then he had some liver function tested, kidney function tested, MRI scans of his chest and brain, because he started to have this brain fog. But his main concern is GI issues. So thyroid function was normal. Everything seems to be okay and great in blood, but GI issues again. He can run to a toilet 15 times in 10 minutes. It's uncontrollable. He had colonoscopy, everything is fine. And person basically is stuck because he doesn't know how to treat it. He doesn't know whether it is related to any medication, but this is something that appeared after catching second COVID. So the question is to you both, have you seen any similar cases in your practices, in your studies, that have both CFS, maybe GI, breathing issues, brain fog, so a combination of symptoms, and how do you deal with that? So any Irina or Varvara, I'm happy to comment.
So yes, I do have patients like this. And that's a good question where you start, because, you know, any point you cannot overwhelm someone with a multiple recommendations at the same time. So the most importantly for me to see what's the main issue. And seems like with your patient, you have GI issues is being the most bothersome at this moment. Of course, there are more, that, brought him there or her. But I would first see what exactly the digestive issue. So is it, you mentioned diarrhea, or is it like fecal incontinence?
This is very severe diarrhea, yes.
Yeah, diarrhea. So I would start, and assuming you cannot order any extensive stool test, right? So you
All
kind
samples were taken, everything is normal. So there is no virus in his GI tract.
So, and we are not looking at this case because, again, virus can be already gone, but the job that it's done is done already. Sounds like that there is more of the SIBO going on there, in addition to irritable bowel syndrome, which is pretty much
SIBO. Let's decipher it for everybody. It's a small bowel overgrowth syndrome. Yes.
Yes, so basically it's a dysbiosis when the normal microbiome is being disturbed by either, again, I'm not sure if this patient had any antibiotics, usually it's the cause, but it might be also disturbed by virus. There definitely, we know that COVID can affect bowels and make that more inflamed, and it's not really a secret that there are some GI issues like the diarrhea being one of the COVID symptoms. I first would make sure that just, again, it's very difficult when you kind of don't know what is going on microbiome there, but basically I do offer some kind of probiotic just to start with, because you have to get somewhere. You have to make sure that you introduce something good and potentially help. You need to make sure that based on the stool characteristic, it's possible that there is some also malabsorption, going on. So you will play maybe with a different type of fibers. We have lots of supplements that can help. Potentially the digestive enzymes might help. If there is any other symptomology like, bloating or potentially that acid reflux, it might be also you need to choose the digestive enzymes with biles. It's all based on exactly, you have that long conversation. You're saying what happens when you eat proteins, what happens when you eat fat. So, and you have to play, I guess, trial and error, because you cannot really see which one, what direction the microbiome goes with that exactly patient. And then just to make sure that overall you kind of trace, maybe having some kind of diary of what their food intake, like what kind of groups of food they have and what reaction they have in too. Because we know that in these unstable conditions, people develop food sensitivity. Speaking of that, we're not even testing for food sensitivity at this point, because, very rarely we do that, because it's pointless. They stabilize their microbiome and decrease that inflammation in the colon and intestines. Then eventually, if you exclude the groups that producing the symptoms, and then slowly introduce one by one, that's what your basically treatment and diagnosis for food intolerance. And then also I would address that from the point of decreasing overall inflammation. Anja mentioned, and again, I'm not sure if you can order it in your country, the slabs, but you can check what is specific antibodies to a certain endotoxins. And again, based on my practice, I commonly do East Candida antibodies. When I see them in blood already, the high levels, then I know that there is what they call leaky gut. It means that there is a really a problem of that, sipping some of these toxins and bacteria into the mainstream. And that also will have some implications, because I prefer to treat with herbals, though in severe cases, when I know exactly which agent I have based on the lab results, I'll do then specific triggers of antibiotics, what we have here. But if I just guessing, I can start with multiple. There is the huge choice of herbals that have that antimicrobial activities, and that might help too. So again, you can pretty much ask them to try and see if that is going to work for them too.
Often see some GI problem with post-COVID syndrome more often when with chronic fatigue syndrome. And I personally believe that there is a combination of two factors. One factor is regarding to microbiome, and we in Russia we also have not only stool tests but also mass spectrometry of microbial markers in blood. It's very helpful to diagnose the increased or decreased level on some bacteria and viruses in the gut. And the second factor is irritable bowel syndrome. For example, if our patients have absolutely normal colonoscopy and endoscopy, maybe the problem is irritable bowel syndrome, which is very common in chronic fatigue syndrome, for example. And in this case, we should address motor function of gut with different treatment for irritable bowel syndrome. And regarding microbiome, we usually have some prebiotics and probiotics, and in Russia we have bacteriophages, for example, phages which eat bacteria. And I would like to ask you about herbal medicine. What herbs do you consider?
Basically, I like the combination that it could include Rossi and potentially there are berberine. There are lots of other combinations. I prefer not to use the single ones, but just certain preparation that includes multiple. And I can give that list, after our meeting. I can send you an examples of what we using. You cannot overwhelm patients with all of this, multiple interventions. So you have to pick and choose. Obviously, everyone has an access to something that can improve their microbiome. Like I said, the probiotic, the prebiotic, and also certain enzymes, because again, if the indigestion is the reason of absolutely.
Okay, and one more question. How do you diagnose leaky gut? It's a very popular issue among patients and in Russian patients too, and a common term. But how to diagnose leaky gut in clinical practice?
Well, again, this is based on the symptomology, and we have a supportive evidence on the lab. We do have lots of, like you mentioned, blood tests, the antigens. The most common, what I'm seeing, I check our patients regularly if they have complaints of, let's say, bloating. I do see lots of increased candida antibody. So for that matter, this is a good clinical point to trace too. If you have some antimicrobial agents introduced. And then also based on the diary. So they have every single visit, I'm asking them what the characteristic of your stool, what is the food groups you eaten, that causing the symptoms you think, what's the correlation. We do have actually in our practice, the nutritionist who will have an additional visits with them. So they will document that too. And besides the education, they also will diagnose that as a part. If you have ability to have the stool test, so you will have this absolutely showing on a certain labs will have the designed test specifically for these conditions. So you will see that there is certain enzymes are not there, or they're low, or they're high. They have all the bacteria, the parasites, the fungi. They have all of this. They have fecal fat. They have a different presentation based on how diverse the microbiome. So they do all of this, the pathogenic growth. So you will see all of this on this test results, which is very beneficial. That's why we're doing it, and it's not that horribly expensive. So we do all of this as a supportive measure, and also as to track our progress.
Sounds really great. I don't know. You are really lucky to be there, and
I know.
This patient must be really lucky to work with you.
We do stuff like this in Russia too, and probably Varvara can say something about that too, but I'm more familiar with the scene in Moscow, and we do have those complex microbiome tests, which are also not terribly expensive, and they could be done multiple times, because you certainly need to monitor what's going on with microbiome in longitudinal perspective, before treatment and after treatment, and see the progress of the patient with reducing some pathogenic species if they are found there. And also, I think it's very important to notice this parameter of diversity of the bacteria, because as more diverse microbiome is, as more stable it is, and it is less likely to be shaken by any single thing happening from the morning to the evening. And there are things which can help into the fixing up the microbiome, but those are things longitudinal, meaning that the health of the colon only need to be nursed to health, rather than you have a magic pill and then all is disappearing at the next day. I hope that everybody can agree with that.
Varvara and Irina, do you see in your clinic or in your study, I don't know, children, do they have very similar symptoms, or the diagnostic is very different for children?
Well, I'm an adult nurse practitioner, so by definition, I don't see children by choice, and by my scope of practice. But we do have children that have been treated by other clinicians there. And I can tell you with kids, we have to be more careful, usually not being that aggressive. But in my field, we see more of pandas, unfortunately, more Lyme pediatric patients. Again, I'm not having any of them, but I do have some consultations with other clinicians. So yes, we do have them. With COVID, again, in US, we don't have yet, hopefully we won't have this problem as a post-COVID with kids, though, only time will tell what the impact of COVID we have on pediatric. I hope that we will get vaccination approved for at least starting from 12 and up soon, before it's all coming to that heartbreaking point. But as far as chronic fatigue, it's not going with the kids usually. Kids are more, I see more of the hyperactivity kind of, diagnosis, which I don't want to bring that in our conversation yet. But as far as if we have a suspicion of Lyme co-infection with kids, that's usually how they present.
In post-COVID group, we also have some children. Actually, we have their parents with long COVID, and their parents noticed that their children also have some symptoms of long COVID syndrome.
Yes, unfortunately, in the UK, we see quite a huge number of children suffering with long COVID. And the problem is that the long COVID clinics that initially were initiated for patients are not taking kids. And people are now struggling to identify right pediatrics to help and deal with the long COVID syndrome. And unfortunately, the kids are as young as 5 who really struggle with long COVID. So it's a huge problem that definitely needs to be diagnosed and more research to be done on kids as well. Yeah.
Okay, thank you very much.
Thank
All right, guys, thank you. We will meet another time. I think we have a great group of physicians here and the researchers who are working with this problem. And surely as more questions would come, we would discuss them, and hopefully it would be interesting for everybody who is watching this video. Thank you. Bye.
Thank you.
Goodbye.
Thank you for inviting us to this discussion, and I'm happy to share patient experience with you and learn more from your expertise from research perspective and medical perspective. And it's really nice to share this practice across the globe.